Yeah, my second presentation of today is about infection definition criteria of NeoIPC surveillance. Just briefly to explain, we talk about a lot of criteria, definitions while using surveillance, and the logic behind is obviously surveillance systems are used by a lot of different centers. In usual cases, like a lot of hospitals that form a network, can be a national network, international network, that with a lot of people entering data with different backgrounds, so can be nurse, can be doctors. So in such a system where with so many sources of data, we can easily end up with having a data pool very heterogeneous, and everybody thinks one thing and assumes that that is the correct definition of this element entity. But as you might know, for example, an infection might a clinical case might be an infection for a doctor in X hospital, but for another doctor or nurse in another hospital might mean another infection or not even an infection. So in order to avoid this heterogeneity in our data set, we should define criteria. We should define our data elements well, so we are sure that we speak the same language and we call the same entities in the same way. After this little introduction, I would like to directly talk about our infection definition criteria. As said, we focus on hospital-acquired infections, which are nosocomial infections that are hospital-acquired infections. And right at the beginning, before I go in detail what kind of infections they are, I want to talk about the definition of hospital-acquired. So for us, infections, for NeoIPC surveillance system, infections where the first symptoms occur within the 72-hour window after birth shouldn't be considered as nosocomial infections. They are usually infections that are transmitted vertically from the mother of the kid during the birth or before birth. So they should be considered mostly as vertical transition, and the late onset infections that occur after 72 hours should be considered as hospital-acquired infections. But it's not such a strict rule. If there are there can be exceptions to it. If an infection begins in this time period in the first 72 hours, but it's a clearly hospital-acquired infection. Like in this example, the patient had a clear signs of local infection on the catheter entry site in these days, and then later start to have fever, and it's most likely clearly a catheter-associated sepsis. You can count this sepsis as late onset sepsis and submit it into the platform. And other way around, if an infection starts late after 72 hours, but it's clearly vertical, for example, infections caused by these like toxoplasmosis, rubella, etc., you don't have to submit this infection as a hospital-acquired infection. And the day of infection, as I said, is always a day of first symptoms or first positive diagnostic test. So they are the infections that we collect data on: primary sepsis, NEC, pneumonia, surgical site infection, and optionally secondary bloodstream infection. I would like to start with the definition criteria of primary sepsis / bloodstream infections. It's divided in two in our system. We collect data both on clinical sepsis, in which we don't have a detected organism of the patient, and laboratory confirmed bloodstream infections are the sepsis that we have a organism that is isolated either from blood or cerebrospinal fluid. Also, laboratory confirmed bloodstream infection is divided in two, depending on the organism that was isolated. It can be either a clear pathogen or a common commensal that usually don't cause infections in human, but for vulnerable patients and vulnerable patient groups like neonates with most probably a lot of devices, they might cause infection. So we have a little bit different definition criteria for this event. So I start with clinical sepsis criteria. As you see, the criteria is an absence of a positive culture, blood or cerebrospinal culture, and then we need a treatment with 5 or more days of intravenous antibiotics, and at least 2 of these clinical or laboratory features. So if all of them meets our clinical case, you can report this case as clinical sepsis. I would like to draw attention to this criterion. Treatment with 5 or more days of systemic antibiotics was initiated, intravenous antibiotic was initiated. The word initiated is here important because if the patient dies, discharged, or transferred before the 5-day treatment was ended, you should still count that. You should still count this criteria as fulfilled, because importance is that the intention of the physician. The second. Now I go to talk about laboratory confirmed bloodstream infections. The first one is the infections caused by recognized pathogens. It's basically only one criterion: if the pathogen was recovered, isolated from blood or cerebrospinal fluid culture, the condition is met, and you can report this case as sepsis caused by recognized pathogen. So now I will have 3 alternative definition criteria for laboratory confirmed bloodstream infection caused by common commensal. As I said, it can be a little bit tricky to understand if it's a real sepsis or if it's a contamination. And also neonates are patient groups that are hard to get blood samples from. So we have 3 different alternatives for that. The first one is the most classic definition of common commensal sepsis, in which we need at least 2 blood cultures or cerebrospinal fluid cultures collected on the separate occasions with the same common commensal isolated. That works very well with adult patients, but as you might know, it's sometimes very hard to draw blood from very low birth weight infants. So in some cases, it's not possible to meet this criterion. That's why we created some alternatives, and obviously always these 2 clinical and laboratory features must met in order to call this sepsis. In the second alternative, we have one positive culture with common commensal, but we have a mandatory laboratory criteria, at least one of them. And then on the bottom part, we have at least 2 of the following clinical and laboratory features again. And on our third alternative, again, we have 1 positive culture, but in this time, we don't have a mandatory lab criteria. We did it on purpose, considering that not every hospital, in every setting might have the chance to conduct laboratory tests so easy. So we, as an alternative, we again use this criteria that we used in clinical sepsis: minimum 5 days treatment, antibiotic treatment. And again, at least 2 of these following laboratory and clinical features of general infection. So we have several different definitions for sepsis, but I hope that I could explain it in an easier way. The next infections don't have such complicated definitions. I go on with necrotizing enterocolitis. Here we have 2 alternatives. You can call an infection as NEC. in case either you have a combination of these two sections, which are following the radiological sign and clinical sign, a combination of radiology and clinic, or at only one of these surgical findings would be enough to define an infection as NEC. So this is a screenshot of our NEC datasheet. I would like to quickly show this section under the surgical and pathologic findings. You'll see, in addition to these two criterion we have, intestinal perforation. It's important to know that it's not a definition criteria, it's just data we collect for later data analysis purposes. So if you only record this, mark this part, it wouldn't be a NEC criteria fulfilled. You would need, again, either a combination of the upper part or one of these. This is only for data analysis purposes. So pneumonia definition criteria consists of a combination of one imaging finding that suggests new changes of pneumonia, such as infiltrates, shadowing, opacifications, etc., and a respiratory criteria, and a combination of this clinical and laboratory criteria, at least 4 of them. So here in this section, I would like to talk a bit more in detail of this respiratory criteria, because it may sound a little bit confusing. So in order to fulfill the respiratory criteria, our patient must have at least 2 days of stability or improvement in the respiratory state. We call it baseline period. If you see here, the patient 1 had, for example, here for 3 days on and on, no device, and the respiratory situation was stable. On day 4, the respiratory state deteriorated, and patient received support via CPAP, and on day 5, no improvement, and CPAP continues. In this example, the patient already receives respiratory support with relatively high oxygen demand on the first 2 days. On day 3 and 4, the oxygen demand decreases and the patient is improving, which are our baseline periods, again, day 1 and 2. And then in these dark blue days, the respiratory state again deteriorates and oxygen demand again gets higher. So after at least 2 days of stability or improvement, which are our 2 light blue baseline days, new initiation of respiratory support or escalation of existing level of respiratory support. In the first example, you see the new initiation of respiratory support, which is through CPAP. And in the second example, you see escalation of existing level of support that you see from the higher oxygen demand. That doesn't improve within less than 2 days. As you see, this deterioration lasted at least, in both of the examples, at least 2 days. There is no improvement in 2 days. So in these cases, our respiratory criterion for pneumonia would be fulfilled. The next infection is a surgical site infections. As I said in the earlier, in the first presentation, we have 3 kinds of surgical site infections, depending on the level of the infection. That can be superficial incisional, deep incisional, or organ space. Superficial incisional SSIs, the definition criteria is met when infection obviously involves only skin and subcutaneous tissue of the incision, and first symptoms occur within 30 days after the operation. That was our follow-up period for superficial incisional SSIs, and patient has at least one of the following clinical criteria. Deep incisional SSIs, basically very similar, but we should always keep in mind in deep incisional SSIs and organ space SSIs, if an implant was left in place, the follow-up period can it will extend to 90 days after operation. So we should follow up the patient up to 90 days if implant was left in place. An infection in this case involves deep soft tissues of the incision, such as muscle layers, facial layers, and one of the following clinical criteria. And organ space SSIs, the infections that involve deeper body parts, such as organs or spaces that were manipulated during the operation. If our infection involves these deeper parts and the first symptoms occur 30/90 days, depending on the implant, and the patient has at least one of these following criteria, our organ space SSI definition criteria would be fulfilled. So the last infection, which is an optional one, secondary bloodstream infections. We collect data on secondary bloodstream infections that occur due to pneumonias, NECs, and SSIs. We have two criteria to record an SSI in our surveillance system. The first one is a time criteria. The blood specimen for this SSI, a secondary SSI, should be collected in the period between 3 days prior and 13 days after the day of primary infection. The primary day of primary infection is the day of the first symptoms or first positive culture of the primary infection site. And the second criteria is a lab criteria, the organism that is isolated from the blood or cerebrospinal fluid must match the organism that was isolated, identified from the primary infection site. If these two criteria is fulfilled, you can report this as a secondary bloodstream infection. So, thank you very much. That was my second presentation. If you have any questions, please don't hesitate to ask. Also, I couldn't obviously explain every criteria we have for every infection, but we have an infection definition document where you can read everything in more detail. Thank you.